I'm going to talk today about abnormal smears, or Pap tests or Papa-Nicolau tests, depending on where you live. And none of these descriptions are actually true because, in fact, we test you for HPV now. But I'm really going to try and just explain to you why people have an abnormal smear, to perhaps try and reassure them that they're going through a preventative process. But before we do that, I'm just going to clarify or repeat a video that I've already uploaded, or part of a video I've already uploaded, just to remind us what the cervix is and where it is. So here it is.
In this video, we're going to talk about the cervix, which is part of the female reproductive tract situated in the woman's pelvis. The uterus is central in the reproductive tract and is connected to the fallopian tubes either side. Next to the fallopian tubes are the two ovaries, which can be seen here. The vagina connects the uterus to the outside, and the lowest part of the uterus, which projects into the vagina, is called the cervix. So let's zoom in on this area now.
This is a sort of what we would call a sagittal view, so taking someone from the side, similar to what Damien Hirst did to his shark and his sheep. So we're looking at the uterus and the vagina. So here is the uterus, here is the cervix or the neck of the womb, and here is the vagina. Now, the lining of the womb is lined by large mushy cells. Now, if you're a doctor, that would be adenomatous cells or glandular cells, but large mushy cells. And they're really designed for pregnancy, perhaps keeping babies warm, and implantation of the placenta. The vagina is lined by skin cells, hard, flat skin cells, or squamous cells if you're a doctor. And on the cervix, there's an area where the hard, flat skin cells convert to the large, mushy cells. And that area, which is not a single junction, but an area, we call the transformation zone. Now, in your vagina live viruses, bacteria, and fungus. Now, it doesn't sound very nice, but everyone's got it, and we call it the normal flora. And some viruses get into your vagina from intimate activity, and that is quite a normal function. And one of these viruses is called the HPV, or the human papillomavirus. HPV can get into these cells at this area in the transformation zone. It's a bit of a design fault because the hard, flat cells protect against infection, but if it's not a complete covering or there's a break in that area, the HPV virus can get into the cells of the cervix. Now, there are over 100 different types of HPV. They're all very similar and they're all given numbers from 1 to 100. Type 6 and 11 cause genital warts, but they do not cause cancer. So if you have genital warts and you're worried that this means you might develop cancer, please don't worry. There are other types which we are associated with the development of cancer in a long time in the future, and examples of these include 16, 18, 31, 33 and 45. Now, there are some other types as well, such as 51, 52 and 68, and these are called the high-risk types. That doesn't mean that you're at high risk of developing cancer, because if you're having your regular smears, perhaps having your vaccine when you're a child, you're not going to get cancer, but you just have to go through the process of prevention in the same way that you brush your teeth and see the dentist. Now, HPV can get into your cervix and cause something we know as CIN. A lot of people call this precancer. I don't like the term precancer because it uses the word cancer, and it is not cancer. A lot of people have been diagnosed and had treatment for CIN and think they've been treated for cancer. They haven't. It's not cancer. It stands for new cells in the skin of the cervix. Now, we doctors would never call anything new cells in the skin of the cervix because it doesn't make us sound clever. So we call it cervical intraepithelial neoplasia. But it's just words, Latin derived, for new cells in the skin of the cervix. Now, Americans use different terminology, and I probably should include this because it might be an American watching. Americans call it SIL, or squamous intraepithelial lesion. But it's all the same thing, roughly the same thing. The terminologies differ very slightly. So with CIN, there are three types. There's CIN1, CIN2, and CIN3. And the Americans would call CIN1 low-grade squamous intraepithelial lesion and CIN2 and 3 high-grade squamous intraepithelial lesion. It's not completely identical, but roughly the same. Now, we know that about 70% of people with CIN1, it just goes away on its own, untreated. So generally speaking, if you've got CIN1, you'll probably just be observed over a 6-month period, 6 to 9 months. If you've got CIN2 or 3, there's probably about less than a 20% risk over a 10 to 20 year period of developing cancer. But that means you're in the group where we want to do something preventative. And often we will take out a small sugar cube sized piece of tissue from the neck of the womb. That's called a comb biopsy, which is a generic term. In the olden days, we used to do a knife, and we call that a knife comb biopsy or a cold knife comb biopsy. We then used lasers. Lasers have slightly gone out of fashion because they're expensive and dangerous instruments, and also they tend to take out a slightly bigger piece of tissue. Then we have a LETS or a LEAP. LETS is the English term, large loop excision of the transformation zone. My American colleagues like to use the term LEAP, loop electrical excision procedure, but they're pretty well the same thing. Then there's NETS, needle excision of the transformation zone, loop comb biopsy, fissure comb biopsy. A fissure is a sort of instrument designed to only go into the cervix a centimetre. And then there are ablative treatments which have slightly fallen out of fashion, especially for high grades, because you don't get a piece of tissue you can analyse at the end. But they include diathermy, which is electrical energy, laser again, something called cold coagulation, which is actually heat treatment. It's not cold at all, but it's only 100 degrees, so therefore it's called cold coagulation. And then some people talk about cryotherapy. Cryotherapy is not a treatment for CIN. It doesn't go deep enough, but just including it as it has been suggested to be a treatment in the past. A lot of people ask about hysterectomy. It is occasionally used for recurrence, but really it's a much too big a deal for something as minor as CIN, which can normally be managed in the outpatient under local anaesthetic or no anaesthetic. The problem with this treatment is that most of these treatments, if performed multiply or a large treatment is performed, it can be associated with premature labour and miscarriage in a subsequent pregnancy. It can also cause something called cervical stenosis, where the neck of your womb closes off. So we don't like to do this treatment unless we have to. But if we do have to, you don't need to worry, because one treatment probably has only a very, very small increased risk. But just be cognizant of the fact that we're quite cautious, and if we can go down a conservative line, we do. Now, the problem with CIN is that you need to take a biopsy. You need to have a 3-dimensional piece of tissue to diagnose it. And I'm going to have another video on HPV at a more cellular level in the future. And hopefully this you can access. But you have to have a biopsy to diagnose CIN. Now, sometimes people do what we call CIN treatment, which means you have an abnormal smear, you have a colposcopy, the doctor sees something that they think is CIN3 and offers you treatment on the spot, and that's perfectly fine. But a smear test, and remember now that we only do cytology on a smear test if you have a positive HPV, only samples the cells on the surface of the cervix. So that can't pick up CIN. Excuse me. It picks up something slightly different. And of course, we doctors don't like to call anything simple like changes on the surface cells associated with CIN. We call it dyskaryosis. And you can have mild, which some people think equates to CIN1, not exact 100%, but that's the equivalent. You can have moderate dyskaryosis, which equates to CIN2, and you can have severe dyskaryosis, which equates to CIN3. And then if you've got normal, which most people's smears are, you've got borderline nuclear change, or BNC, in squamous cells, which is an area between. And we often call mild dyskaryosis low grade and moderate and severe dyskaryosis high grade. However, you've got to understand that a smear is probably about 60% accurate, which is why when you have an abnormal HPV, you then get cytology. If your cytology is abnormal, you get referred to colposcopy. So just to finish the terminology off, there are some other terms. CGIN is cervical glandular intraepithelial neoplasia, which is where there's abnormalities in the large mushy cells. My American colleagues call it adenocarcinoma in situ. Treatment involves moving tissue higher up the cervical canal and normally involves some assessment of the lining of the womb, such as an ultrasound or a biopsy. SMILE is a very rare form of CGIN. It stands for stratified mucinous producing intraepithelial lesion. These are histological diagnoses that can only be diagnosed from a biopsy. American terminology is often different to the UK terminology. In America, they use a term ASCUS, atypical squamous cells of uncertain significance. That's the equivalent of our borderline nuclear change in squamous cells. And you can also have glandular abnormalities or in borderline cells, so you can have borderline nuclear change in a glandular abnormality, and that should be treated in a similar way to CGIN. A smear can be inadequate and might need repeating. So generally speaking, having an abnormal smear does not mean you've got cancer. Very few people present with cancer with an abnormal smear. It is part of a process. It's a part of a preventative process to prevent you from developing cervical cancer in the future. Thank you very much.